everyone. Today I'm going to be discussing pneumonia, which includes community and hospital acquired. And for a little background information, there's two types. So, as I mentioned, community acquired is pneumonia that's acquired outside of a hospital setting, and hospital acquired is something that usually occurs at least 48 hours after hospital admission. So, the key word is here going to be 48 hours after hospital admission. And there's two types of bacterial causes. So, there's typical. The most common one you'll probably see is Streptococcus pneumonia. And as you can see from the other ones, so H. influenza, Staph aureus, Klebsiella, it's kind of a mix between your gram negatives and gram positives. And this will include basically the common symptoms you would think of pneumonia, such as the fever, the productive cough, so the sputum in it, purulent sputum, pleuritic chest pain, and then rigors. Rigors is kind of like a violent shaking, so like chills. Then you have your atypical ones. So this is stuff like mycoplasma pneumonia, Legionella, which will probably be the one you'll see most likely for atypical presentations. And just to note that atypical Legionellas usually come from contaminated water sources such as like air conditioners, showers, cruise ships, air filters, etc. And then you can also have viruses, which includes your influenza A or B or an adenovirus as well that cause it. And their symptoms tend to be less severe. They tend to be more extrapulmonary manifestations. So that could be like your diarrhea, sore throat, earaches, and just note that most of these atypicals tend to have resistance to beta lactams, and you usually cannot see them on a grand stain. So your treatment for these ones will usually be like something like azithromycin. Next is like how we assess the patient, and we do something called the CURB 65 score, and we award each 1 point for each factor of presentation. Um, and this sort of gives us an indication of whether the patient should be hospitalized or if she should be as an inpatient or an outpatient. So the stuff we kind of look for are like your concussions, the urea over 7 millimoles per liter, the respiratory rate usually between 30 breaths per minute. So a normal respiratory rate is usually between 10 to 20. Um, Blood pressure less than 90/60. So typically, usually a normal kind of blood pressure usually is about around the 120 over 80. And then of course you got your 65 years and older, and elderly are always most affected in all these kind of scores. And so like I said here, 0 points will be your outpatient, 2 points will be your inpatient, and greater than 3 will be your ICU. So you typically, I think some people get confused when to use the CURB 65 score. So the CURB 65 score usually comes basically after you see the presentations. So then you kind of have to do your socials and a medical history to kind of figure out how we should treat this patient. Should they be treated as an outpatient? So that would probably include monotherapy, or should they be included as an inpatient, which may require like combination therapy, or an ICU, which may require IV. So some exams will kind of like give you cultures and tell you what kind of bacteria would you suppose this is. So for example, Streptococcus pneumonia will come in gram cocci pairs, so it's gram-positive cocci pairs. H. influenza, so this will usually be some kind of underlying respiratory disorder. Just note that if H. influenza is present, you do need to add oseltamivir to your antibiotic therapy as well. Klebsiella, so this one usually comes from chronic alcoholism. It also has the same shape as E. coli, so it's kind of got that rod gram-negative shape. Staph aureus, that one's gram-positive, but that one's in clusters. And mycoplasma pneumonia, which usually occurs in more in young and healthy patients. And you're also going to get the extra pulmonary systems because, as we said, it is an atypical. So these ones right here are your typicals, and then these ones will be your atypical. So Legionella, the most important one, which is what I mentioned earlier, is the outbreak with contaminated water source. So that could be hot tubs, shower installation, cruise ships, AC, and it can present with hyponatremia, confusion, bradycardia. Um, and just remember with the atypicals, they don't present on the gram stain as well. So usually treatment's going to be a minimum of about 5 days. Other factors can increase this to 21 days. It's important to note that if symptoms resolve within 5 days, it is okay to stop the therapy. So um, reasons you may want to stop therapy is, for example, a patient may be presenting with symptoms of C. difficile, and as you know, some antibiotics can make the presentation of C. difficile even worse. So in that case, usually you can stop the therapy and then treat them with empiric antibiotics. Therapy in children is usually about 7 days though. So community acquired outpatient. This is a mnemonic I got from Cram the Pants YouTube channel. So it's you're freaking mad you got pneumonia, which is going to include our fluoroquinolones. And remember, because of the side effects of fluoroquinolones, you're only going to use this if like it's um kind of if other comorbidities are present, like so patients kind of like a little bit moderate to high risk, but not severe enough that they need to be hospitalized. And then you got your macrolides. You'll probably run into azithromycin the most. Um, and then you got your amoxicillin and your doxycycline. And then community-acquired inpatient, things are getting freaking bad. So this one, you might get fluoroquinolone monotherapy or most likely triple therapy, which is going to include like a beta-lactam or plus your azithromycin or clarithromycin and your doxycycline. So that would be the bad. And usually want to do this at a low dose if they have comorbidities like a heart or lung disease or diabetes, etc. And then hospital acquired, so if you got Pseudomonas, you got a few options for that ones. Probably the most notable ones are the cefepime and ceftazidime. Um, if you watched one of my other videos, there was like a little mnemonic, which is if you if you sue, you won't get a dime from me. So ceftazidime. And then cefepime is we also said that you won't get a dime and you won't get some pi. So Pi and then E, pime. And then you also got your piptaz, respiratory fluoroquinolones. Obviously, your respiratories are your levo and moxifloxacin. Macrolides, they're your imipenems, meropenem, and azathioprine. And if you remember with your carbapenems, the exception for Pseudomonas is ertapenem. So that's why you don't see ertapenem in this one. Because remember, for the E is for exception, ertapenem. So ertapenem does not cover Pseudomonas, but the other carbapenems do. And then you got your MRSA, and then of course you already know which one is going to be your main player for this, which is your Vanco, and then your linezolid. And then for something like Legionella, this one will usually be your macrolides, preferably azithromycin. And the reason we do it is because there is no cell wall. So that's why when we do a gram stain, you won't see them on a gram stain. You can also use fluoroquinolones. Remember, these are kind of like just a last resort if there's no comorbidities, just because the adverse effects kind of outweigh the benefits of using the medication. And then you also got your tetracyclines, and then you got your sulfamethoxazole trimethoprim, or sulfatrim basically, as your last line. There's also aspiration pneumonia. So the next ones I'm going to talk about you probably won't even see, but I just wanted to do it for completeness, in case maybe one day they become more of a problem in the future. So seen in critically ill patients with reduced consciousness, and it's usually from excessive alcohol use as well. And most common culprit will be your anaerobes producing kind of like a foul smelling sputum. And you're going to treat that one with amoxiclav. Histoplasmosis is a form of spurs from bird or rat droppings. This one you're going to give itraconazole. And then pneumonia cystitis is caused by P. giravici, which you'll likely see in AIDS patients as well. I honestly, with histoplasmosis, I don't even think you'll run into this one that much, um, unless you're like in a place where there's like a lot of caves and rivers. And then aspiration pneumonia, probably the only spiel you'll get about it is like what causes it, and which is usually your anaerobes. I think maybe there was one more about the P. giravici. Yeah, so treatment is with your sulfatrim, and it's also prophylaxis as well. And it's just important to note that you're going to give this medication even if the patient is pregnant, and that's because the benefits of this medication kind of outweighs the risks in treating the P. giravici. Okay, so hospitalized empiric treatment. Usually this includes IV ampicillin. If there is respiratory failure or septic shock, then you want to give a third generation cephalosporin. So if you remember the mnemonic, if you try taxing me, you won't get a dime. So that's your ceftriaxone, um, cefotaximime, and your ceftazidime. Now remember, do you remember which one was the one that covers Pseudomonas? So that would be your ceftazidime because of the if you sue me, you won't get a dime or pi. If you remember that the fourth generation cefepime also covers Pseudomonas. You may also want to add a macrolide if it gets really severe and you just want a speedy recovery as well. And if a patient has a penicillin allergy like anaphylaxis, most people's first instinct is to pulled the cephalosporins, but remember, this is a patient that's hospitalized and they're in a severe state. So the course of action that you would take in this case is you want to observe them for 30 minutes when they take the dose with an epinephrine on hand to administer in case they go into anaphylaxis. Some other factors to be kind of mindful of, and this is just sort of just in terms of the ADRs. So that would be like QT prolongation. Remember that your macrolides and fluoroquinolones will exacerbate QT prolongation. So you want to be careful with certain medications that the patient may be on. So for example, that might be something like your amiodarone or methadone. Those are the ones that are coming to my head at the moment. There's also red man syndrome with Vanco. And remember with Vanco, you got to do slow infusion and you got to watch those trial levels. So if you remember, it's kind of like something like this. So the trial levels are down here and your peak levels are up here. So peak levels, more risk of side effects. Trial levels are efficacy. And remember that you also want to watch out for the side effects of nephrotoxicity and autotoxicity with vancomycin as well. And then we can't forget about CYP interactions. So clarithromycin is a really big one. So that one inhibits like something like CYP3A4. And then also there is ciprofloxacin, which may inhibit CYP1A2. But I can't really think of a lot of medications that usually use the CYP1A2 except coffee and but nicotine's an inducer. But coffee was probably one that uses the CYP1A2. I think one of the SSRIs uses it, but I can't remember it off the top of my head. But yeah, clarithromycin, big one, CYP3A4 interaction. And then also your C. difficile infection. So remember, these are your drugs that usually start with a C. So that can be your clarithromycin, ciprofloxacin, clindamycin is a really big one as well, and a majority of your cephalosporins as well. And in this case, you want to stop any unnecessary therapy and perform a NAT test, and then you may need to initiate empiric therapy as well. And then pregnancy, you may want to avoid doxy, fluoroquinolones, sulfatrim as well. And then remember with your carbapenems, there is a seizure risk if you use imipenem. So that has the highest seizure risk out of all of the medications as well. And yeah, that's pretty much kind of it was a quick summary of pneumonia. I'm kind of hoping this might help for your exams as well. And yeah, if there's any other topics that you kind of want me to like summarize a little bit to make it easier for the exams, just kind of let me know. Thanks. Good luck on your exams.